Wow. So this is the future? The future of cardiovascular medicine? Could this be? Often in life, our biggest limitation is our lack of imagination. That's not something we can afford. Not in cardiovascular research. No one knows where the science will lead. But what we do know is that we must keep pushing ourselves to dream bigger and bolder, to dare ourselves to imagine what might be. Perhaps a 4D CT scan that identifies vulnerable plaque well before any event occurs. A test that uses such little radiation, patients could be checked repeatedly throughout the year. And if vulnerable plaque were detected, perhaps we could offer our patients a revolutionary new type of PCI. One with a more precise, more sophisticated stent that we could just inject into the bloodstream and then watch them travel to the exact blood vessel where it's needed, where it's been pre-programmed and where it can elegantly expand in that place. Who knows what might be possible 10 years from now? But do we dare to dream? To dream of taking genetic engineering to the new frontiers, creating heart valves with re-engineered tissue, or actually removing the whole heart from the body to make any type of repair easier, more precise. Even better yet, will we one day create a whole new organic heart entirely from scratch that we could implant in the body? This is all so exciting. But wait, I should get back to today. Hold on.
That's so much fun. To let yourself dream of what might be. And before we go any further, for the record, if any of you develop such a CT scan to identify vulnerable plaque, you hope you present it here at ESC Congress. I'm just putting in an early request. For now, welcome. Welcome to ESC Congress 2018. A heartfelt welcome to 5 days of exciting science and exceptional networking. It's so great to look out and see so many friends and colleagues in this hall. Meeting like this each year is a time for us to reflect on our profession, on how far we've come and where we are going. In short, what it means to be a cardiologist today. This is such an exciting time to be practicing. We have so many more sophisticated tools and resources at our disposal, both diagnostic and therapeutic. We can now see the heart, its anatomy and function, in amazing detail. In just the last 20 years, we've introduced revolutionary imaging modalities. Real-time 3D echo, CT angiography, fusion imaging with PET-CT. We can now look inside the coronary arteries to detect thrombosis and inflammation. We can see fibrosis in the ventricle and strain on the heart. We're moving rapidly into big data and machine learning, providing even more refined insights into the disease process. And we have so many more effective ways to treat cardiovascular disease in all its forms. We can now replace a valve with a catheter. We can occlude the left atrial appendage to prevent a stroke. We can resynchronize a heart that's out of phase. We have LVADs as small as my hand and pacemakers as tiny as my fingertip. Again, this is all in just the last 20 years. In the time that many of you have been practicing, there's no question we've come a long way. But you know, as well as I do, with impressive advances come significant challenges. With so much focus on new technology, are we losing sight of the person we are treating? Too many patients say they feel like a machine, a broken machine, coming into the repair shop. And we are the mechanics, detached and impersonal. Yes, we get the job done. But patients today need something more from us. They need empathy. Empathy, the action of understanding, being aware of, being sensitive to the feelings, the thoughts, and experience of one another. To look in a patient's eyes and understand the anxiety, in many cases the panic that their lives might suddenly be cut short. They turn to us, not only to fix their hearts, but to calm their fears. They need us to connect with them. I know what you're thinking. We don't have time. We're under pressure to handle more cases more quickly, more rapidly. We barely make eye contact with the patient. We're so focused on entering data into the medical records. I thought computers were going to give us time, more time, to make our practice easier. But what happens? In some hospitals nowadays, a cardiologist's day is 30% providing care, but 70% administrative tasks. The growing number of checklists and requisition papers and approval forms. That is not why we became physicians, and that is not why we became cardiologists. Most of you and most of us are here today because we were drawn to the profound humanity of this profession, the humanity of medicine. And the fact is, we need this interaction with the patient as much as the patient does. And the farther we're getting away from this model, the greater our own frustration. It is no wonder that cardiologists today report some of the highest rates of burnout in medicine. A recent survey of ESC members in 17 countries found that at least a third of doctors said they were emotionally exhausted. A third. It's contributing to divorce and depression and medical errors, and growing numbers of cardiologists are leaving the profession. This is a major threat to healthcare. The ESC needs to say to policymakers in Europe and beyond, if you want healthier patients, you need healthier doctors. We must work together to find the solutions, all of us, because if we don't, then who will? Here at ESC Congress tomorrow afternoon, you're invited. You're invited to a special session on burnout, sharing your experiences and exploring solutions. As you've seen, year after year at ESC Congress, we're constantly adapting our program to address your specific needs. But we recognize that ESC Congress is first and foremost about research. It's the summit of cardiovascular science, from every subspecialty and super subspecialty, from more than 150 countries, and featuring more than 4,000 abstracts, presented like nowhere else. Each year, when you walk around ESC Congress, look closely at all the color and lights and the way the science is showcased. The message is unmistakable. ESC Congress is a celebration of discovery. Again, thank you for joining us here this year. This is going to be such a remarkable event. So let me now turn to my good friend and distinguished colleague, Stefan Achenbach, the chair of the Congress Program Committee, to tell you more about what's in store for you. Stefan?
Thank you very much, Jeroen. Dear ladies and gentlemen, dear colleagues and friends from all of Europe and in fact all around the world, welcome to ESC Congress 2018 in Munich. And first I would like to thank Jeroen Baks, ESC President 2016 to 2018, for giving me the opportunity to lead the Congress Program Committee for last year's ESC Congress in Barcelona and this year's Congress in Munich. It has been a tremendous honor to work with a group of 81 dedicated men and women from all over Europe and in fact several colleagues from all over the world and other continents. And the picture shows the group in front of the Heart House in Nice, headquarters of the European Society of Cardiology, and listed are the names of 12 colleagues and friends to whom I am particularly grateful, the topic coordinators who worked with immense dedication and who were absolutely instrumental in making ESC Congress what it is. 5 days with an extremely rich program full of the latest science and clinical knowledge. This year's Congress spotlight is valvular heart disease, and it has been selected because of the recent progress regarding the management of valve disease and the completely new options for treatment that have come about with the catheter-based techniques. The activities around the Spotlight topic are focused in the Spotlight Village, and you will see many sessions regarding new technology, the substantial implications for imaging, and all other aspects, not only in aortic valve stenosis, but of course the entire spectrum of valvular heart disease. Over the next days, you will be able to follow lectures and participate in demonstrations, debates, discussions, and interviews that cover the entire field of cardiovascular medicine. This is your Congress, and the program has been designed with two major aims in mind: to provide you with up-to-date clinical knowledge, advice, insight, and skills on one hand, and to present the latest research findings, to discuss them, to interpret them in the context of clinical cardiology on the other hand. For the abstract-based content of this meeting, we have received more than 11,000 submissions from countries all over the world, and every single one has been extremely carefully reviewed and graded. And as Jeroen mentioned, more than 4,000, in fact 4,461 abstracts will be presented and discussed in 70 poster and 142 oral presentation sessions. Among the highlights for any large meeting is the late-breaking science, as we call it, and I'm certain that once again the trials presented at ESC 2018 in Munich will be something to remember. We will have 14 late-breaking science sessions dedicated to specific areas, such as arrhythmia, imaging, or even telemedicine, and 5 hotline sessions in this main auditorium will showcase the most important trial, which covers a wide range of important questions in cardiology. And let me give you some examples. What is the role of aspirin in primary prevention of cardiovascular events such as myocardial infarction? The ARRIVE and the ASCEND trials will look at this specific question. Is oral anticoagulation beneficial in patients with heart failure and coronary disease even without atrial fibrillation? Commander HF was conducted to investigate this issue. What is the optimal antiplatelet strategy after stent placement? Global leaders may tell us that aspirin may have a very small role and potentially should be given for only 4 weeks. Very important with our Congress Spotlight. MITRA-FR is a prospective randomized trial to evaluate MitraClip in secondary mitral regurgitation with heart failure, looking at mortality as outcome. ATTRACT is tafamidis finally a beneficial treatment for patients with cardiac amyloidosis. We are all seeing such patients ever more frequently. And more clinical questions. High STEAX, will the use of high sensitivity troponin improve outcomes in suspected acute coronary syndromes? And finally, POET, can we treat patients with endocarditis orally instead of intravenously with antibiotics? These are just some examples of clinically relevant information that we can expect in the hotline sessions at this Congress. New guidelines are issued at every ESC Congress, and this year we will see the 4th universal definition of myocardial infarction and 4 clinical practice guidelines of tremendous importance. They include the guideline on myocardial revascularization presented on Monday, the guidelines on syncope and cardiovascular disease in pregnancy, and finally, extremely important, written jointly with the European Society of Hypertension, the guidelines on arterial hypertension, which will be presented in great detail tomorrow on Sunday morning right here in this auditorium. Besides the abstracts, late breakers, hotlines, and guidelines, the extensive educational and scientific program is the core of your Congress. It allows you to truly get updated with current cardiovascular topics, from basic science to public health, from hypertension to heart failure, from imaging to intervention, and from surgery to sports medicine. There will be 368 sessions in 15 different session formats, and the faculty includes 1,613 speakers coming from a record 76 countries. We never had more. We have placed strong emphasis on providing sessions of very high clinical relevance, on having global experts in cardiovascular disease share their knowledge and insight, and on creating ample opportunities for interaction, questions, and discussions. In fact, special rooms have been designed, including the so-called library room that is particularly suited for panel discussions. And I would strongly like to encourage you to download the mobile app and use it, because the mobile app is essential to have the best possible experience at the Congress. It gives you all the information that you need, and in addition, allows you to vote, to ask questions, and to rate presentations and sessions. And finally, let me mention ESC 365. This is the one website that gives you access to all Congress material all year long. On ESC 365, you can watch every single presentation given, every discussion, every debate taking place at this Congress, including slides, videos, spoken text, whenever and wherever you want. All you need is your login to the European Society of Cardiology. Dear colleagues and friends, thank you for coming here. Thank you for choosing ESC as your Congress. Thank you for your contributions, and thank you for being part of this community. I wish you wonderful days in Munich, and enjoy ESC Congress 2018.
Great. Thank you. Thank you, Stefan. Nobody could have done that better than you. Thank you so much. Each year, ESC Congress is held in some of the most beautiful and dynamic cities of Europe. And this year, we're excited to be back in Munich. As we do wherever we go, we like to give back to our host city by staging a public event to promote heart health, especially nutrition and physical activity. And this year, with the help of the football club Bayern Munich, we're showing a typical team workout. We're playing this video on large screens, challenging the public to keep pace with their football heroes. It's all good fun and provides important heart health messages. If there's one thing we've learned, it's that promoting heart health requires extraordinary leadership from all over the world, from all walks of life. Social crusaders, like the one and only Barbara Streisand.
What's up, Doc?
I beg your pardon.
We've got to stop meeting like this.
Who told you you're allowed to rain on my parade?
Hello, darling. Well, hello, darling.
Come with me, and you'll be in a world of pure imagination.
Hello, gorgeous.
Ms. Streisand is a relentless champion in the fight against heart disease, especially when it comes to women and heart disease.
Yes, being alive.
At Cedars-Sinai Medical Center in Los Angeles, she established the Barbara Streisand Women's Heart Center, which she discussed for ESC Congress in this interview with our colleague, Dr. Noelle Berry-Mertz.
Thanks, Jeroen. Barbara, thanks for taking the time to do this.
My pleasure.
When did you first get interested in women's heart disease?
I discovered the staggering number of women who die from cardiovascular disease and that so few resources were put toward women's heart research. I found out the statistics. I mean, 1 in 3 women die of heart disease and stroke, whereas 1 in 32 women die of breast cancer. But the United States spends almost 10 times more research funding women's cancer than heart disease. Heart disease funding needs to go way up. That's the point, to help the number of women that are affected. Also, we need more women participants in clinical trials. How can we optimize diagnostics and therapeutics for women if we're not including more of them in our research?
Barbara, why don't more women know their risk?
The Women's Heart Alliance survey that we conducted found that a lot of women are embarrassed about having heart disease. Some women aren't even aware they have it. And many people think heart disease only strikes old men. Women are not making a personal connection to heart disease or sharing their stories. More people lose loved ones to heart disease than they realize because these deaths are often falsely attributed to natural causes or ailments. But in my opinion, there is nothing natural about a woman or a man dying of heart disease, dying at 35 years old, 40 years old, 29 now.
You have thousands of cardiologists from all over the world at the ESC Congress in Munich watching this interview. What message would you like to give them?
I want to thank you for the research you're doing that's expanding the boundaries of cardiovascular medicine, allowing millions more people, men and women, to lead longer, healthier lives. Also to all the clinicians who are on the front lines in this all-important fight against cardiovascular disease. Being at the ESC Congress, you are demonstrating your commitment to being up to date on the very latest science and to giving your patients the best care you possibly can. I applaud you all, and I wish you a truly successful meeting.
A special thanks to Barbara and to Noelle. As mentioned earlier, our profession has made such great strides over the last 20 years. Millions of people are alive today because of the many advances in cardiovascular medicine. But none of this would be possible without the partnership, the creative collaboration between academic medicine and industry. And to provide insight into this unique partnership, we are greatly honored to have a man this year who is arguably the world's dean of cardiovascular medicine, Dr. Eugene Braunwald. His work has dramatically expanded our knowledge of coronary artery disease, heart failure, valvular disease, just to name a few. He is the editor of the premier cardiology textbook, Brown-Wold's Heart Disease, now in its 11th edition. From Boston, Massachusetts, please welcome our distinguished guest, Dr. Eugene Brown-Wold. Thank you.
Professor Box, thank you for this generous and somewhat exaggerated introduction. I'm pleased to be here and to have the opportunity to share some thoughts about the relationships between academia and industry. These are some of my disclosures. So, the modern history of cardiovascular medicine and surgery is one in which the cardiovascular community can take great pride. In the last 65 years, life expectancy in the industrially developed nations of Europe and North America has increased by about 20 years, or 33%. A large fraction of this is due to a reduction or delay in the development of coronary artery disease. The appreciation of the critical role played by low-density lipoprotein cholesterol, LDL-C, in atherogenesis and in the development of the means to reduce it represents one of the great triumphs of modern medical science and of academic industrial collaboration. The story begins with these two men. On your left is Adolf Windhaus, a German organic chemist who carried out seminal studies on the chemistry of cholesterol, for which he was awarded a Nobel Prize in chemistry. In 1910, he was the first to report that aortic plaques are rich in cholesterol. On the right is Nikolai Anichkov, who as a young experimental pathologist worked in the military academy in St. Petersburg. In 1913, he fed huge quantities of cholesterol to rabbits and found that this induced atherosclerotic lesions in the aorta. Here shown are Konrad Bloch and Feodor Leinen, who shared the Nobel Prize in 1964 for their pioneering work on the chemistry of cholesterol and fatty acids. Leinen was born in Munich, and he became director of the great Max Planck Institute here in this city. Bloch was also born in Germany, but he was forced to emigrate. He became chairman of biochemistry at Harvard. These two scientists were honored for elucidating the 30 separate steps responsible for the biosynthesis of cholesterol, which formed the basis of much of the subsequent work in the field. Here are shown Joseph Goldstein and Michael Brown, both trained in internal medicine, cell biology, and biochemistry, who have and continue to work closely together since 1972 at the University of Texas in Dallas. They identified receptors for low-density lipoprotein cholesterol on the cell surface. Now, they showed that when LDL-C becomes attached to these receptors, which you can see at the top left, they are internalized into the cell by endocytosis, and the intracellular cholesterol causes feedback suppression of the production of new receptors and inhibition of HMG-CoA reductase that you see on the right in red. This is the rate-limiting step in the synthesis of cholesterol, which was previously identified by Konrad Bloch. Now, in contrast, in a condition called homozygous familial hypercholesterolemia. The LDL receptors are not active, and cholesterol fails to enter the cell. Its concentration rises in the plasma, and this plays a critical role in the formation of atherosclerotic plaques. Goldstein and Brown isolated, characterized, sequenced, and cloned the LDL receptor, and for this they were jointly awarded the Nobel Prize in 1985. Now, the 6 scientists that I've mentioned so far were all academics working in universities or in 2 instances, not-for-profit research institutes. While their scientific accomplishments are dazzling, they represent only a part, albeit a critical part, of the story. In the early 1970s, several pharmaceutical companies were screening compounds derived from bacteria and fungi in the search for new antibiotics. Akira Endo, a scientist at the Sankyo company in Tokyo, also tested these fungal products for their ability to inhibit cholesterol synthesis. 2 years and more than 6,000 tests later, he and his small team came up with a remarkably potent inhibitor of HMG-CoA and thereby of the synthesis of cholesterol. Now, Brown and Goldstein, working 6,000 miles away, lost no time. Within a month of Endo's first publication in an obscure journal in 1976, they requested a sample of Endo's inhibitor, subsequently named Compactin. Now, in the spirit of optimal academic industry collaboration, Endo granted their request. Goldstein and Brown quickly confirmed Endo's findings, and they reciprocated by inviting Endo to their laboratory to plan further considerations. What they found was further, they showed that Compactin, by inhibiting HMG-CoA reductase, reduced cholesterol synthesis and hence reduced intracellular cholesterol. This resulted in an upregulation of the LDL receptors, which contributed importantly to the lowering of circulating LDL. So Endo and his team back in Tokyo then showed that Compactin reduces circulating LDL in patients with hypercholesterolemia. So the race among pharmaceutical companies to develop statins was on. This slide shows on the left Roy Vagelos, an outstanding biochemist, a member of the National Academy of Sciences of the United States, who was president of Merck Research. He invented heavily in this program. On the right is Alfred Alberts, the Merck scientist who headed the group that isolated lovastatin, the first statin that we know. So Brown and Goldstein were generous in their praise of their colleagues in industry. They wrote, "Without Endo, the statins might never have been discovered, and without Alberts, Vagelos, and Skolnick at Merck, statins might never have become approved drugs. The millions of people whose lives will be extended through statin therapy owe it all to Akira Endo and his search through fungal extracts at the Sankyo company." So the story that I've summarized briefly demonstrates academic industrial relations at their best. The basic research was extraordinary, but despite their 5 Nobel Prizes, these scientists and their universities and research institutes were not equipped, and they did not have the know-how to develop an efficacious and safe, powerful drug. To accomplish this, industry, with its massive intellectual and physical resources, was essential. There are dozens, perhaps hundreds of other examples in which academia and industry have had joint supporting roles. Two recently developed drugs in cardiology are the PCSK9 monoclonal antibodies, which further reduce LDL cholesterol, and of a drug, sacubitril neprilysin, for the treatment of heart failure. There are many examples of triumphs in cardiology with devices, pacemakers inserted, defibrillators, drug-eluting stents, transcatheter aortic valve replacements, left ventricular assist devices, in which engineers in industry have played critically important roles and have been life-prolonging. Now, I believe that investigators working in academia and in industry share common overriding goals to improve health. Both groups also want the results of their work to contribute meaningfully to these goals. Investigators working in academia obviously have responsibility of teaching students, as well as training and mentoring the next generation of scientists. Investigators in industry are expected, by developing clinical advances, to enhance the financial return to the investors in the companies which employ them. Investigators in industry often receive performance-driven bonuses, which may be in company stocks and which provide additional incentive to reach their research goals. There has been concern that these financial considerations might introduce some bias into the interpretation of their research. However, we have to remember, before a product can be registered and marketed, the design and results of the supporting studies are carefully assessed by the staff of the regulatory agencies, often working with independent, knowledgeable academic reviewers. This helps assure the accuracy of the findings. Ideally, the research of academic investigators is the disinterested search for the truth. But like their counterparts in industry, academic investigators also have a lot riding on the outcomes of their research. These outcomes influence their future research support, their academic rank, and in many instances, their salaries. Therefore, both academic and industry investigators are strongly motivated to achieve positive outcomes of their research. Academic investigators, like their industry colleagues, have not been immune from concern about financial matters and concern about bias. As shown on this slide, there is a wide spectrum of relationships between academic investigators and industry. Some have absolutely no financial ties, which is rare for clinical investigators. Frequently, the academic institution receives a grant or contract from industry which contributes to the academic's salary. Many academic investigators serve as occasional consultants or on advisory boards for which they receive compensation directly from the company. Now, problems can arise when academics receive a significant fraction of their income directly from industry. Examples are include academics serving as spokespersons for specific products or delivering a series of sponsor-developed lectures. These activities may be quite rewarding financially, but they often result in the academic's objectivity being questioned. More serious conflicts of interest arise when academics own stocks or even serve on the boards of companies that support their research. Such behavior can sometimes undermine public confidence in the objectives of biomedical research. Fortunately, there are now strict rules for the complete disclosure of industry relations in all journal articles and public presentations, like I made my disclosure at the beginning of this lecture. These disclosures are an example of the adage that sunlight is the best disinfectant. In addition, the ESC and other major cardiology organizations have developed ethical rules about academic-industry relations. Importantly, universities and their teaching hospitals and not-for-profit research institutes have also developed specific rules for their faculty members' relations with industry. These rules should be enforced, but enforced intelligently. In conclusion, what about the future? I've been privileged to have observed many of the advances in cardiovascular medicine in the last 6.5 decades. I believe that the recent advances in genetics, chemistry, bioengineering related sciences, and the management of big data have placed us on the brink of even more exciting advances in clinical cardiovascular research. In a health policy statement sponsored by the American College of Cardiology, Bhavani and colleagues have examined these revolutionary opportunities. They fall into several categories, but as you can see, they're all interconnected. And on this last slide, I've listed some examples extracted from the preceding slide. Time obviously doesn't permit discussion, but one thing is clear. Collaboration between academia and industry will become even more important when applying these emerging technologies. While we take pride in the accomplishments of cardiovascular research of the past 65 years, I believe firmly that the best is yet to come. Thank you for your attention.
What a great lecture.
Thank you.
Fantastic. Thank you for sharing that with us. As a token of appreciation, we would like to hand you this plaque, reminding of the excellent lecture and the fun meeting that we have. Here you are. Can you hold this outside? Okay. Just I will put you. We go there together. It was fantastic. It was fantastic. At each ESC Congress, we have the privilege of honoring several cardiologists who have made extraordinary contributions to our field. Our first gold medalist for 2018 is a renowned cardiac surgeon focused on valvular heart disease. In the early 1990s, he developed the edge-to-edge mitral valve repair technique, or as you know, the Alfieri stitch, the precursor of the current mitral clip. Ladies and gentlemen, from San Raffaele University Hospital in Milan, Professor Ottavio Alfieri.
In the 70s, I was a young doctor, full of enthusiasm, ideas in my mind, projects and energy. At that time, cardiac surgery was just out of the pioneering phase. Transplantation was already available, and also the first artificial heart was implanted in 1969. I made my choice, and since then I've been very happy because I did this job with a lot of joy, enthusiasm and passion. I was inspired by the observation of a congenital anomaly which is a little bit rare. I operated a patient with an ASD with a double orifice mitral valve. I looked through the ASD and I could inspect the mitral valve. Later on in the day, I had to operate a patient with a prolapse, anterior prolapse of the mitral valve, and I created double orifice mitral valve, just reproducing what I was looking in the morning. The result was excellent, with no incompetence of the valve, no stenosis, and importantly, the operation was done in very few minutes. The simplicity of this type of repair was very attractive to innovators looking for new methods. So the mitral clip was exactly the replication of the edge-to-edge repair. The edge-to-edge repair is the basis for the most commonly used percutaneous method for mitral valve repair nowadays. So this is certainly something which makes me proud. And I'm very proud to have surgeons who trained with me to be real masters, not only in conventional surgery, but also in transcatheter procedures. I'm proud because I create now a foundation which is going to support innovation, research and developments in cardiology in general at San Raffaele University Hospital.
Okay. Congratulations, and please allow me to hand over to you the gold medal of our society.
Okay, thank you very much, Rune.
Photos. And please say a few words.
Okay, what to say? It is indeed a great honor for me to receive this recognition from the European Society of Cardiology. I have to say this is a double honor because I am a surgeon, and this shows how inclusive is the European Society of Cardiology. Being here today with so many people coming from all over the world in this big auditorium, receiving this prize, you know, I have really the deep feeling in my heart that the edge-to-edge repair, the concept of the edge-to-edge is now in the heart of the cardiological community. And is considered something that can be very useful to our patients, particularly those suffering from a severe mitral regurgitation and even tricuspid regurgitation. It was like a dream, actually. 20 years ago, more than 20 years ago, when I started with this, I couldn't imagine this evolution. obviously, I'm very happy of this evolution, and I'm very proud. Again, many, many thanks.
Thank you, Ottavio. Our next gold medalist for 2018 is the president of the Russian Society of Cardiology and the Director General of the Almazov National Medical Research Center. His work has been summarized in more than 800 publications, includes 16 inventions, 2 scientific discoveries, and a number of monographs. Ladies and gentlemen, from St. Petersburg in Russia, Professor Evgeny Slatko.
Already in my students' year, I was attracted to experimental study in cardiovascular area. Later, during more than 20 years, I was working with Professor Almazov. It was really advanced research that time, 70s, 80s. I was personally involved in the investigation of neurogenic regulation of blood pressure in patients with arterial hypertension. And my publication was during students' period. I was very proud. Over the past decade, Almazov Center became one of the largest and biggest medical research centers, not only in Russia, but in Europe. Now we are aiming an extremely ambitious national goal, raising the life expectancy in Russia up to 78 by 2024. To do this, it's necessary to shift the focus of activities from emergency care and primary prevention to the high-risk group. In one sentence, rapidly developing, successful, and optimistic. The decrease in cardiovascular mortality is now about 20%, and I am really proud that I was able to start building a bridge between molecular biology, genetic, and clinical cardiology at the beginning of this century. And today it gives us tangible results, not only in clinical practice, but also in the training of the doctors.
Evgeny, please come up. Please accept the gold medal of our society, the highest honor that we have.
Thank you very much.
Please say a few words.
Dear colleagues, dear friends, this is a great honor for me to be awarded with the ESC gold medal. I am really proud to be in the family of the very, very important cardiologist. But I believe this is not only my appreciation, this is also appreciation of the Russian cardiologists and their efficiency during last years. Russian cardiology very successful today, rapidly developing. We have fantastic history with Anichkov, Korotkov, Kolosov behind us, and now we aiming and focusing on the biggest challenges. I believe that the success of Russian cardiology very close to European Society of Cardiology, and we use the all practical experience accumulated in European Society of Cardiology. ESC gold medal is a good chance for development of Russian Society of Cardiology. We have the same challenges, aiming the same goal, to reduce the burden of cardiovascular diseases. That is why we must work together in exchange of ideas, practical experience in cardiology, healthcare management, social activities. Seems to be the good basic level for future success. I will do my best to keep going in this direction.
Okay. Thank you very much, Evgeny. Thank you very much. And now, our last, final gold medalist this year worked hand in hand with Gene Braunwald. He helped to introduce ACE inhibitors to change adverse remodeling after myocardial infarction. He had a principal role in many of the clinical trials that changed all of us, our practices, such as SAFE, Valiant, CHARM, and many more. They are some of the most highly cited papers in clinical medicine. Ladies and gentlemen, from Boston, Dr. Mark Pfeffer.
I was a student. I was working with Professor Edward Froelich in Oklahoma on rats and studying how the heart functioned. And I gave a presentation, and this man came up to me after. I saw his name. I, of course, knew his name. And it was Eugene Braunwald. And our results differed from his. And we talked about the differences. And he invited me and my late wife to be fellows in his laboratory. Actually, the truth is, he invited me because that was the way to get my late wife, Janice, to work there. This field of cardiology is growing all the time, and none of us sees the future. And what we have is we're training the future. And it's our responsibility to give them the world where they can probe and ask their questions. And there's nothing more fun than seeing that mind open, watching a fellow pass in an abstract, have a manuscript that's theirs. They're the first author. When I tell them, if you put this in the mail or you push send and you can feel it's there because of me, that's a great feeling. And keep it going. Keep it going. Well, clinical cardiology is really very evidence-based. But what's happened is we've had subspecialties where it's too much for any one mind to do now, and especially in research. So my fear is that we splinter and we don't really hear each other. Meetings like the ESC bring us all together, and it's a very important opportunity to try to listen, learn, and grow together.
Ladies and gentlemen, Dr. Mark Pfeffer, please allow us to honor you with the gold medal of our society. Take some photos.
Thank you, Jerome. Well, obviously, I thank Jerome and the leadership for bestowing this honor on me, which I will treasure. But as you heard, clinical trials are all about cooperation. It's a we, and the we is international. And I've been very lucky to work with a lot of we's. And we have to thank the sponsors, whether it be governments or industry. We have to thank the study personnel, co-investigators, but most of all, we have to thank the patients for trusting in us. Thank you.
Thank you so much, Mark. Each year at this time, the ESC highlights a charitable organization working in cardiovascular care. The European Heart for Children is a humanitarian project that helps young people with congenital heart disease to get the treatment that they need. It was started by Claudia Florio and Professor Roberto Ferrari. Roberto, please join us on the stage. Please accept this donation from ESC for the charity work that you do for so many years. Please say a few words.
Well, first of all, I accept it with a great pleasure. It's a very good check. And you heard during this fantastic opening ceremony the word dream. And I'd like to tell you that European Heart for Children, when we started 8 years ago, also had a small but important dream. And the dream was to try to help one of our national society and to solve the problem of congenital heart disease. This dream is coming through because from the 1st of September we will start the building of a pediatric unit in Casablanca in Morocco with a public hospital and a university. And that unit will be able to treat, we hope, more than 1,000 patients per year. So the dream is coming through. Thank you very much for this.
Thank you, Roberto, and thank you to your wife to doing all this work without taking anything and just giving. That is fantastic. Thank you so much. The ESC takes great pride in all its philanthropy, especially the financial support it provides to its dedicated young community. Ladies and gentlemen, here are the names of all the ESC grant and award recipients for 2018. We are near the end of this great inauguration ceremony, and we save the best for last, because we get to officially welcome the 257 new fellows to the ESC. This is so very special. We know the time and effort you have dedicated to your research to reach this point, and we salute you. Please watch the screen for the names of all our new ESC fellows. I ask now all the new fellows to please stand and be recognized by your colleagues. Please stand. Congratulations to all our ESC fellows, new and not so new. Indeed, there is one distinguished fellow who deserves very special recognition. He was in the very first class of ESC Fellows 30 years ago. He's also a former ESC president, an inspiration to so many of us. My dear friend, Paul Hugenholtz. Paul cannot be with us in Munich, but I would like to ask his children, Vivian and Greg, to join me on stage to accept this plaque and the official announcement of the new Paul Hugenholtz Lecture on Innovation in Cardiology at every future ESC Congress. Please, here it is.
Thank you very much.
A tribute to your father, a fantastic person, one of the best mentors I've ever had. Thank you so much,
Thank you very much.
and we look forward to seeing him soon again. Paul is a special man, and this honor is richly deserved. Now, without further ado, it gives me immense pleasure to declare ESC Congress 2018, your Congress, officially open. And I invite all of you to join me and the association presidents in the ESC Professional Members Lounge for a cocktail reception right now. To ensure we don't get lost along the way, we've hired our very own Bavarian polka band to lead us there. So just follow the music, and I'll see you in the lounge. Thank you all, and strike up the band.